Hello, everyone. I'm Dr. Mike Broyles, the Director of Clinical Pharmacy and Laboratory Services at St. Bernard's Five Rivers Medical Center in Pocahontas, Arkansas. I would like to thank you for joining me today as we discuss procalcitonin as an aid for risk assessment in COVID-19 or SARS-CoV-2 and influenza-related secondary bacterial infections. From the housekeeping standpoint, I do serve in advisory or consulting functions for several companies. The information presented today is based on my interpretation of the evidence and clinical experience. We've been using procalcitonin for approximately 10 years, and the evidence that I will share with you involves almost 5,000 patients with respiratory tract infections. For objectives, I would like you to be able to summarize the pathophysiology and kinetics of procalcitonin. I'd like for you to be able to describe how PCT can differentiate the types of infection in bacteria, i.e. viral, atypical, and typical bacteria. Cite the incidence and role of secondary bacterial infections in terms of risk and mortality, and apply procalcitonin testing concepts to aid in the risk assessment for bacterial co-infection, severity of bacterial burden, and disease evolution. If we compare the biomarkers that we commonly use for infection today, we've studied more than 275 biomarkers to date. The problem we have is these biomarkers do not have the ability to differentiate between a bacterial infection and an inflammatory response. If we look at white count and we look at the specificity to bacterial infection and the sensitivity to inflammation, we can see that the white count really just shows up in time to say something is wrong. It really does not have the ability to differentiate between the type of infection, albeit a bacterial infection, a viral or a fungal infection, or even a sterile inflammatory response. It just has the ability to tell us that something is wrong and we need to investigate. Indeed, we know that there are 596 drugs or disease states that can affect a white count either up or down. C-reactive protein, on the other hand, actually has a higher specificity for bacteria, which I find interesting because C-reactive protein is one of the tests that we order in rheumatoid arthritis patients. But essentially, it is an inflammatory marker also. It really doesn't have the ability to differentiate any better than the white count. And if we look at its time to peak, it's generally 24 to 48 hours, and it has no correlation with severity of illness. Lactate is a marker that we've used for sepsis. It really has no place in this type of discussion. It is simply one of the markers that we're using for perfusion. So as far as evaluation of antibiotic therapy, it really doesn't have a place. Procalcitonin, on the other hand, is very highly sensitive and specific to bacteria. We generally will cite that procalcitonin is 94% specific to bacteria, and that is the key. It's its ability to differentiate a bacterial infection from a viral infection. And what's very interesting is that procalcitonin is never elevated in the presence of a pure viral infection. One of the key concepts in the use of procalcitonin is simply to understand why procalcitonin is different. It is not a test like a pregnancy test that is simply black or white. It is yes or no. Procalcitonin has a lot of nuances that we need to understand. And this is one of the very important concepts. The reason that procalcitonin is different from all the other biomarkers we studied to date is its ability to differentiate in that it is a bacterial infection only. And this is done through the use of what we call a toll-like receptor. We have elucidated at least 12 toll-like receptors to date. All parenchymal tissues within the body have a TLR or a toll-like receptor. It is part of our immune system, and it is simply an early warning system. It is looking for bacteria, cell wall breakdown components, toxins, anything related to bacteria. And once that happens, that the bacteria sits on this toll-like receptor, then a couple of things take place. The first thing that we see take place is the immediate release of tumor necrosis factor, interleukin-1 and interleukin-6. These products are stored within vacuoles within the cell, and they're released immediately into the bloodstream. They cause that whole cascade of inflammatory events to take place, including the elevation of white count, the production of CRP in the liver, and so on. And what's also interesting is, if you think about it, we have drugs that are tumor necrosis factor blockers, and we have steroids that can affect the release of these compounds. And this is one of the reasons that we have problems with a consistent release of these products, because Oftentimes, these drugs are used in the treatment of our patients. Once the inflammatory mediators are released, then we see another chain of events. Procalcitonin then has to be made by the cells. It takes 3 to 6 hours for that process to happen. Generally, procalcitonin is made and released into the bloodstream within 3 hours, but always within 6 hours. And that's a very important point to keep in mind. Additionally, the other point that is very critical to understand is that once that toll-like receptor is affected, then procalcitonin will be made. As far as we know, there are no mechanisms by which procalcitonin will not be made once the body sees bacteria. One of the key features of procalcitonin is once it is made and released into the capillary system, then it can be measured. The amount of procalcitonin that you see is in direct proportion to the number of bacteria that occupy receptor sites within the body. So for the first time ever, we actually have a direct mechanism to evaluate the amount of bacterial burden within the body. For example, if you have an elevation of PCT, that means you have bacteria that must be sitting on the toll-like receptor, and that is indicative of the amount of bacteria we see. Now, we don't know if this is a diffuse or concentrated amount. We don't know where it's located at, but what we do know is that the higher the value of PCT that we see, it is very much indicative of the numbers of bacteria we see within the body. As far as evaluation of procalcitonin, we generally say that the value of 0.5 nanograms per mil is considered to be a normal value. And it is an upward progression. You'll see these numbers can go as high as 1,000. In most facilities, we report 2 as alert and 10 as a critical value. There's not a magical number at which a patient is in sepsis or septic shock. It's just the higher the value, the greater the cause for concern, and the greater the bacterial burden. So kinetically, we mentioned earlier that procalcitonin is made and released within the first 3 to 6 hours. Its peak, the time once bacteria is seen within the body and that procalcitonin is manufactured by the cells, is around 24 hours. You'll notice it's actually a biphasic peak, kind of plateaus out at 12 hours, but around 24 hours is the maximal amount of time that procalcitonin is made once the bacteria occupies that toll-like receptor. Its elimination half-life is also 24 hours, and just like with drugs, the elimination half-life is the time for PCT to be reduced by 1/2. So we said the peak in this case was actually, for instance, 10, and we had appropriate therapy, then you could actually suggest that 24 hours later, with appropriate antibiotic therapy, that value would be 1/2 or would be 5, and it would reduce by about 50% every day. So elimination half-life 24 hours. And then based on that, the best time to evaluate the effectiveness of your antibiotic therapy is also 24 hours. So kind of in summary is it rises in 3 to 6 hours, peaks in 24, elimination half-life 24, and the best time to evaluate the effectiveness of your antibiotic therapy is also 24 hours. What many do not realize is in February of 2017, the FDA approved Broyles PCT for 2 very important indications. Number 1, it was approved to aid in the decision-making on antibiotic discontinuation for patients with suspected or confirmed sepsis. And then very importantly, it was also approved to aid in decision-making on antibiotic therapy for inpatients or patients in the ED with suspected or confirmed lower respiratory tract infections, which they define as community-acquired pneumonia, acute bronchitis, and COPD exacerbations. Fortunately for us, they provided an algorithm that had 2 pieces. The first piece had to do with antibiotic initiation in lower respiratory tract infections. And so for our discussion, we'll stay away from COPD and we'll focus on pneumonia. So let's just say that if you have a patient who has pneumonia and you're going to follow the guidelines, you're going to initiate therapy, antibiotic therapy on those patients, but then the next day you're going to reevaluate the effectiveness of that therapy and the need to continue. What I would like to point out is this, is that if you'll notice in the antibiotic initiation for LRTI, that essentially antibiotic therapy is discouraged whenever you have a value that's 0.25 or less. And that's important. Keep that number in mind. This is telling us about the relative amount of bacterial burden. And when that value is in that low range, it is highly unlikely to have a secondary bacterial infection. The second piece of that puzzle is that piece of antibiotic discontinuation in sepsis and LRTI. And what you'll notice in this lower left-hand corner is that LR in LRTIs, it is suggested that if that absolute value is 0.25 or less, or very importantly, an 80% drop, which is what you're going to do most of the time, notice the wording that is from the FDA. Cessation is strongly encouraged with clinical improvement. And in sepsis, it's an absolute value of 0.5 or less, or an 80% drop. And so what this is actually doing is providing us with information, particularly in those patients that you started antibiotic therapy on. The next day, that procalcitonin value remains the same. It remains low, normal. Then we have opportunities that we don't have to continue antibiotic therapy. So let's talk the next few minutes about COVID patients, and then we'll shift gears and we'll talk a little bit about influenza patients. Medscape ID published this article in March 13 of 2020, and I think this kind of sets the stage for what we are talking about in our COVID patients. Notice what it says. Step 2, hospital arrival. And then once at the hospital, the CDC's interim guidance kicks in. We recommend obtaining a baseline CBC with DIF, the basic metabolic panel, liver function test, and procalcitonin. The value of procalcitonin, the need here is number one, to establish if there is a secondary bacterial infection, and that's one of the keys, because a secondary bacterial infection always has a higher incidence of mortality and adverse outcomes associated with it. Very important, and it's also interesting, is that many of these patients have leukopenia in about 30 to 45% of the cases. And the more common thing that we see is lymphocytopenia, which is in about 85% of the cases. And then you'll notice that they're using PCR technology to rule out other pathogens. They're looking and saying, is this a human metapneumovirus? This is the rhinovirus, looking for other causes of that clinical presentation as that patient comes in. This next slide was published by myself and all, and it demonstrates the use of procalcitonin to help us differentiate in the cause of community-acquired pneumonia, i.e., is this a viral infection and an atypical organism infection, or a typical and extracellular bacterial cause infection? If you look on the lower left-hand corner, you'll see that in the sample size, there were 409 patients, and that the median procalcitonin value in these patients was 0.09. which anything 0.1 or less is considered to be normal. In this case, this clearly demonstrates the fact that procalcitonin is always low in a pure viral pneumonia. This has been demonstrated over and over again, that when that infection is strictly from a viral cause, we expect procalcitonin to be very low to normal. So if we look at the atypical organisms, our sample size is much less, but you'll see that the mean value is 0.20. While this number may seem small when you compare to the 0.09 that we see in the viral infections versus the 0.20 in atypical infections, we can see that the p-value is still statistically significant. So what this is telling us is that procalcitonin, even in low values with atypical infections, we are able to differentiate between a viral etiology and an atypical organism etiology. Let me point out a couple of things about atypical infections. So in this case, we're actually talking about a mycoplasma or Clonidine pneumoniae. Some of the other organisms, such as Legionella pneumoniae, can produce very high levels, up to 10 nanograms per mil of procalcitonin. So key point is that in these atypical infections that we see, procalcitonin can still produce a statistically significant differentiation, helping us understand that this is a viral infection for an atypical organism, even at this low value. In extracellular or typical organisms, we can see the PCT value mean was 2.5. So again, this is driving home the concept and the point that extracellular organisms can produce quite high levels of procalcitonin, indicate that there is a significant amount of bacterial burden to the body. And with those higher values, you would expect then a higher p-value, and that's what we're actually seeing, a p-value of 0.01. So looking at the procalcitonin data from our hospital in patients with a diagnosis of pneumonia, we have 4,946 patients in this data group. You can see that our lower whisker was 0.16, our first quartile was 0.41, Our mean was just under 1, and our third quartile was 3.27. This is all types of pneumonia combined. But we were able to break that information down, and so if you look in the next slide, you can actually see that we had 2,310 patients who had a pure viral pneumonia. And our median for that statistically was 0.58, so just above what we would report normal as 0.05. I think that's very important. Our atypical median was higher than in the previous group. We only had 341 patients in that group, but our median was 0.312. So we had a little higher differentiation in those patients as far as the amount of procalcitonin that was released. And then in a typical or extracellular organisms, just under 1. So what's interesting is several things. We were still able to differentiate between the type of infection. And number 2 is, remember that now with the change in pneumonia, in community-acquired pneumonia, 1/2 of your patients tend to be of a viral origin, and 1/2 tend to be bacterial origin. This is a shift over the last several years because of the use of vaccines. And this is what we see here. Almost half of our patients have viral etiology, and about the other half have a bacterial etiology. We'll spend the next few minutes looking at some of the data from China. The first one from Chen et al. Looked at 99 cases of novel coronavirus from Wuhan. So what I would like you to notice is that 6 of these 99 patients actually had elevations in PCT, which were actually fairly small. You'll note that interleukin-6 was elevated in a large majority of these patients, and that C-reactive protein was also elevated. And this is what we'd expect. We would see in patients who have a low initial bacterial burden, i.e. there was no secondary bacterial infection, but they did have other disease states, as in this viral infection, you would expect elevations in the inflammatory mediators, interleukin-6, and C-reactive protein. So most interestingly, what we found is there was a low PCT in the majority of cases on admission, indicating that there was not a secondary bacterial infection. The other thing is as expected, is that they had very high cytokine levels. So these are inflammatory mediators, and this was especially true for the very critically ill. Most patients received antiviral therapy for an extended period of time, but if you look, I find this very interesting. Even though they reported 1 case of bacterial coinfection, which really doesn't coincide with the PCT data, you'll notice what it says. Most patients received antibiotic treatment for 3 to 17 days. And so even though the data indicated that they really didn't need antibiotics, they were getting extended courses of antibiotic therapy really without need. And this is kind of one of the things that we need to drive home is we want to use PCT to help us make better decisions. Also interesting is they were showing an 11% mortality rate, which is much higher than we're seeing now, with adult respiratory distress syndrome, or ARDS, being the major complication. The key takeaway, the data support the value of procalcitonin in the differential diagnosis of lower respiratory tract infections, and this is to help us rule out the secondary bacterial infection. In the next paper we're looking at, from Wuhan and all, just under 1,100 patients were available for an analysis. The primary diagnosis was pneumonia, 91% of those patients, and they reported a mortality rate of 1.4, and this is more in line with most of the data that we're seeing out there. A little disturbing is this. Notice what it says in the next bullet point. There's no correlation of radiologic findings or clinical symptoms on admission in relation to the severity of outcome or risk. And so we're always looking for something to help us understand more about the severity of illness, and we're not seeing that in this case based on the radiologic findings. Adverse outcome was seen in 40 and 13% of the patients, which are associated with ARDS and septic shock. So if you look at the symptoms, about 2/3 of these patients had cough, and less than half actually had a fever on admission. This is why this is so concerning. Many people don't have the symptoms, but yet they're shedding the virus, causing the spread of that. And so it's kind of interesting when you actually see this data, and it kind of gives us perspective on some of the challenges that we have. A continuation of the study, we're actually looking at the PCT values. What they were looking at was the composite endpoint for adverse outcomes, which they designed as the ICU admission, need for invasive ventilation, or death. And what you can see is that only 4% of those patients or less actually had an elevation in PCT. Again, that was a low risk or rate of secondary bacterial infection on admission, but you can see the inflammatory mediator CRP was high. And so what's interesting is we had data on about 60% of these 1,100 patients, so somewhere around 660 patients. The threshold level of an elevation of PCT was 0.5. Remember that the FDA algorithm said between 0.25 and 0.5. And we found that they had a low number of patients who actually had significant elevations of PCT, indicating that on admission, they actually had a low incidence of secondary bacterial infections. CRP was high. And so what they were suggesting is that a low PCT on admission provides a low risk for severity of disease and adverse outcomes. In this paper by Zhou et al., they looked at the clinical course and risk factors for mortality of adult patients with COVID-19. And this is interesting. You actually see two parts. There's the survivor section on top, and there's the non-survivors on the bottom. And as with all the data we've seen, ARDS and septic shock were the most frequently reported causes of death in COVID-19. But secondary bacterial infections seem to be a very important contributor to mortality in COVID-19 patients. And if you look across the bottom scale, you'll actually see that secondary bacterial infection begins to occur after the first couple of weeks. So if you have patients who are in the hospital with extended stays, it becomes concerning that they develop a secondary bacterial infection somewhere in that 15, 16-day range. And we need to be aware of that, because elevated procalcitonin levels are associated with a higher mortality rate. That's an odds ratio of just over 13. So indeed, one of the key factors is following these patients to make sure that the PCT does not elevate, and making sure that we actually chase those that begin to develop a secondary bacterial infection. What's also interesting is that in this study, 70% had a PCT less than 0.25 or no coinfection. Now, this is where it begins to get a little interesting. This rate is much different than what we saw in the previous studies. And so this 30% of coinfection is probably more in line with what we see with influenza, and may actually be more realistic to what we're seeing with COVID right now. In the study published by Lepay and Plebano, they looked at procalcitonin values in patients with severe coronavirus disease. In this meta-analysis, what they were trying to determine if they could achieve a 95% confidence interval and a high odds ratio to see if procalcitonin could predict the severity of coronavirus disease. This is an incredibly important point. They demonstrated that increased PCT values are associated with almost a 5-fold higher risk in severity of disease and mortality. This was an odds ratio of 4.76 with a 95% confidence interval. The second takeaway is that PCT was useful in evaluation of the initial severity of infection. That question of, is there a secondary bacterial infection? And thirdly, to address that serial measurements are important to assess the effectiveness of antibiotic therapy, the evolution of infection from a viral to a secondary bacterial infection. This is a very, very important information for us to take home. Let's shift gears for just a few minutes and talk about seasonal influenza. It is estimated by the CDC that last year 61,000 patients died from the influenza virus. So this is a cause and a concern for us. So in this paper from Rodriguez et al., they actually looked at 972 patients who were in the ICU who had confirmed infection without shock. And if you look at this, it provides us some very valuable information. We can see in patients who had a viral infection, the PCT values were low. But in patients who had a bacterial co-infection, that the PCT values were statistically higher. And so what they suggested was this, that if the PCT value was less than 0.29, they suggested that it had a 94% negative predictive value. And so their conclusion again was PCT has a high negative predictive value of 94%. With lower PCT values, it seems to be a very good tool to help us exclude co-infection, particularly in patients without shock. In this paper by Carhu et al., This was a very interesting paper. So what they were doing is they were looking at inflammatory mediators, in particular interleukin-5, interleukin-6, interferon-induced protein 10, CRP, and compared it to procalcitonin. And so they were actually looking to see how the inflammatory mediators stacked up against procalcitonin, but more importantly, what procalcitonin did in infections. And in this published data, you can see that this is actually from several flu seasons. So this is the influenza H1N1. It was the SARS, the MERS, and it now includes the COVID. So what you can see is that VG, that is the viral group, we can see that in patients where it is a pure viral infection, that the PCT values were normal or very, very low. And this is exactly what we would expect. And notice all these achieve statistical significance. In patients who had a bacterial infection, again, we can see that there's a significant elevation in PCT, exactly what we'd expect. And then in patients who had a mixed infection, both viral and a bacterial, again, we see a significant elevation in PCT. And so the suggestion is that a bacterial co-infection with elevated PCTs were seen in many of these cases, and in most cases, an elevation in PCT was tied to higher severity of illness and mortality rate. Let's talk just a minute about what we know about influenza and bacterial co-infection. What's interesting is we know a lot more about the causative pathogens versus the rate of co-infection. We know that the most common pathogens are Streptococcus pneumoniae, methicillin-resistant Staph aureus, and Haemophilus influenza. We now know that respiratory viruses, particularly RNA viruses, have a high nucleotide substitution rate that can undergo resorting during mixed infections and make them not recognizable to the human immune system. So what we're saying is that the presence of bacteria actually makes the influenza virus more virulent, and it also makes it less likely to be seen by the immune system. This then provides us with the fact that mixed infections usually have an increased severity of disease, illness, and mortality. And then, on top of that, the influenza virus and other viral pathogens greatly increase the risk of infection and colonization from bacteria. So both the virus and the bacteria are playing off of each other. Essentially, the bacteria makes it easy for the virus to adapt and to mutate, and then the virus that makes it easier for the bacteria to colonize and be pathogenic. So how does this happen? We have found that there's an increased loss of lung repair function. We have increased death in basal epithelial cells, alveolar epithelial cells, and we have an increased attachment of bacteria to the lung cell walls themselves, and apoptosis, which is programmed cell death. We know that antibiotics should not be routinely given to patients with uncomplicated influenza. I mean, that's the whole issue. Is the question becomes, at what point do we give antibiotics, and then how long do we give them? Another issue is that antibiotics clearly should not be given to prevent bacterial complications, and this is one of the temptations for many clinicians is I'm going to provide them antibiotics just to make sure they don't get that secondary bacterial complication, which is against the stewardship guidelines. Klein et al., they did a meta-analysis that was entitled Secondary Bacterial Infections Associated with the Influenza Pandemics. They actually found the range to be between 11 and 35%. For years, many of us said, this range is around 20-ish% for secondary bacterial infections. But notice what we have in the second part of this sentence. It says in the 2000 swine influenza epidemic, the rate was 29 to 55%. Well, this is interesting because it's higher than the other rates that we've seen, and it may suggest that the bacterial co-infection rate may vary with the type of influenza virus that we're seeing. In the paper that was done by Morrison et al., the frequency of influenza and bacterial co-infection, a systematic review and meta-analysis, they said this range could be up to 65%, which is much higher than we've seen with the others. Obviously, the problem is we don't do viral and bacterial cultures on everyone, so it's hard to know exactly what that rate is. The bottom line is this. Many people now have a co-infection. We need to know, is there a co-infection, and then we need to look at opportunities as far as antibiotics. But the rate is much higher than probably what we realize. Let me give you a case example of a man that we've had recently. This is FL, a 79-year-old male. His chief complaint is he comes in, he says, I just feel like I have the flu. It's a rapid onset, the durations and symptoms for about a day and a half. Temps are about as high as 103. His respiratory rate is 20. His pulse ox is 92% on a room air. He has increased shortness of breath on walking and moderate exertion with no past history of shortness of breath, productive cough, nausea, and vomiting. We have two presentations here. We have presentation 1 and presentation 2. Presentation 1 is the initial presentation, which he was admitted to the hospital for 3 days. 3 days passed, and then he returns to the ED for presentation 2. So if we look at the comparison between the two, we see that actually very similar. We look at respiratory rate, blood pressure, temp, all very similar. Where we begin to see some differences is that of the pulse ox, we see 92 versus 89% on room air. White count actually slightly higher in the first presentation, but the key is this. You'll notice in presentation 1 that his PCT value is 0.07. So this is indicative of no bacterial burden. This is a normal procalcitonin value and suggests that he probably does not need antibiotic therapy. Now, if we look on presentation 2, we can see that his PCT value is 1.23. This is clearly indicative of a bacterial infection and requires the use of antibiotic therapy. So if we look at the chest X-ray on the first situation, we actually said questionable minimal infiltrate in the right base, possible atelectasis. So not a lot of useful information. Chest film in the second case, increase in right basilar airspace opacity could represent atelectasis or infiltrate. So we see in the first situation where the patient presented with a normal PCT, we repeated that PCT the next day and it remains normal. This confirms to us then that there is not a secondary bacterial infection and that he didn't present early. If we overlay the white count with the PCT, we can see that there's an elevation of white count, which is as we would expect. This is an inflammatory mediator. So in the first situation, we simply provided him with oseltamivir and no antibiotic treatment. Now, if you thought that his pneumonia, if he had, quote, pneumonia, was important, and you began antibiotic therapy, okay, we'll give you that. If you start antibiotic therapy, then the next day you have a PCT value that is normal, then that would be your opportunity to stop antibiotics if you feel compelled to treat this man with antibiotics initially. In our situation, we just opted to give him oseltamivir. In the second situation, you can see the PCT was significantly elevated at 1.23. If we overlay the white count with it, we can see again that elevation in inflammatory mediators, but there's a couple of very important points. In this situation, he was treated with ceftriaxone and vancomycin. The vancomycin for the MRSA and the ceftriaxone for the Streptococcus pneumoniae and for the Haemophilus. So we're providing coverage for those organisms that we would suspect we would see in a secondary bacterial infection. Also note this, if we go from day 0 to day 1 and from day 1 to day 2, we see about a 50% reduction in PCT values, which are telling us then that our antibiotic therapy was successful because we're seeing that ideal 40 to 50% reduction in PCT values. So if you look at day 3, you'll see that this arrow says stop antibiotics. This represents an 80% reduction, or in this case also an absolute value of 0.25 or less. So what I'm suggesting is that this man went home on day 4 without an additional antibiotic. So he only received 3 days of antibiotics. Hence, we were making a decision based on his body's response to the antibiotics and his own immune system. And we know that that level is low enough that he'll do well. So in summary, the most common pathogens in bacterial co-infection are well known. We know that. But the rate of co-infection has not been precisely elucidated and apparently varies by the type of influenza virus. The co-infection rate, even at the lower reported estimate, is actually quite high. I mean, even if we think in the terms of the 20-ish percentile versus some of the others, is that a lot of these patients who are coming in are going to have a bacterial co-infection. And remember, it's key that we treat these people early. Co-infection from bacteria clearly increases the severity and the mortality risk. Early intervention is the key to reducing this risk and mortality. Procalcitonin testing is a very important tool in the differential diagnosis of bacterial infection and bacterial infection in the influenza and the COVID patients. Serial monitoring can help detect the evolution to a more severe form of disease. So remember those patients that we said in the one study, the survivors versus non-survivors, and somewhere around that day 15 or 16, that's where we saw that secondary bacterial infection. So it was key to monitor those patients to make sure that that bacterial infection didn't progress. Additionally, you may have a patient that has a shorter stay but has a change in status, and you want to get an additional PCT to evaluate that patient to make sure they have not developed a secondary bacterial infection. And we've demonstrated very clearly that PCT will be very low in pure viral illnesses, but it will be elevated in bacterial coinfection and pure bacterial infections that are providing us with the ability to differentiate between a viral versus a bacterial or a coinfection. PCT can help with severity assessment of bacterial burden. It can help us with the evaluation of our antimicrobial choices, and it may provide shorter durations of therapy. If you have any questions, this is my personal email address. It's mbroyles@suddenlink.net. If you would like to send me questions that you don't feel I adequately answered, questions that we didn't cover, or a request for a PDF version of this presentation, feel free to contact me. I'll be glad to provide that information to you.